Hey everyone, and welcome to the FLATLINING Podcast from Fulcrum Strategies. I'm Matthew Handley, and with me is our president and CEO, Ron Howrigon. Hi, Ron.
Hey, how are you?
I am doing all right. We're talking today about two things that are both Medicare related. One, I think we could call it some good news, and the other, I think we can call it some bad news. The good news is, Ron, is that Congress somehow, I think by the grace of God, got their act together and negated some of the Medicare fee cut. Unfortunately, it's not all of it, and it seems to be some kind of weird voodoo math that they've done to make it work. So I know a lot of our clients have been asking about it, especially those that see a lot of Medicare patients. So what exactly happened, and what does this mean going forward for the 2024 Medicare fee schedule?
Yeah, what happened is, like you said, Congress got together and they realized that the proposed cuts were too much. They didn't do what I would have hoped they would have done, which is get rid of the entire cut and give an increase, but they got rid of some of it, roughly half, if you will, of the cut. So March 9th, and I have no idea why they picked that date, dates of service will be paid about 1.6% more than the dates of service with Medicaid that were prior to that, which is still, roughly 1.7 or so percent less than they got paid last year.
Right.
So in an inflationary environment, we're still getting paid less than last year. The doctors are, but more than what we otherwise would have been paid before this action. So I guess it's good news, not great news. And one of my clients said they're still beating us up. They're just beating us slower now.
Yeah. Yep. I guess the question that a lot of providers and practice administrators and billing companies might have is that if you've got a contract that is based on current year Medicare, is that contract necessarily going to pay at the new 2024 fee schedule now, or is it going to be dependent on the situation?
It's going to be very dependent on the situation. Okay. And this is not the only year where inside of a year there were two versions of Medicare. So it really depends on, does the language say the then current, at which point I would argue it needs to adjust to the new fee schedule, or does the language have some other policy tied to it? Some plans say, well, we pay according to the rate on January 1st, at which point this change won't change the rate at all. So it really is very contract and situation specific.
Last question I have on this particular issue. We got a lot of clients in North Carolina. North Carolina, I think, is one of the larger payers right now, pushing a current year Medicare fee schedule onto its physicians. They do something, they do something a little bit weird where it seems they roll it out on April 1. Do you know if the April 1 rollout for the current year Medicare for North Carolina for Blue Cross Blue Shield, is that going to be the A or B fee schedule for 2024?
So in all likelihood, it's going to be the A schedule,
okay. The
January 1 schedule. What Blue Cross of North Carolina used to do is they would base it on what they called first published fee schedule, which would be, for the 2024 Medicare would have been the fee schedule that got published in late 2023. That's the fee schedule that a lot of times would get changed at the 11th hour. So then they went to, we'll base it on the January fee schedule, but we won't roll it out until April to give us time to get that loaded in our system. So even though they haven't rolled out the new 2024 reimbursement, based on their policy, it will still be based on the January schedule, which is that full cut.
Mm-hmm. Well, you can find more about Medicare fee schedule on our website, fsdoc.com and flatlining.net. I want to switch gears a little bit now to talk about another big news item, and that has to do with Medicare fraud. We hear a lot about individual Medicare fraud cases. I found some things that have popped up over the years, Ron, about, telemedicine owners having some Medicare fraud. Sometimes you get nurses. You had Operation Brace Yourself a couple of years ago by the DOJ. But last week or the week prior, Aledade, one of the largest primary care chains in the country, is facing a whistleblower lawsuit that they have been improperly billing Medicare and boosting their patients. And so, Ron, I guess the first thing that I want to ask you is how big of a deal is it that Aledade is being named in this whistleblower case?
It's a huge deal. especially if they're proven, found guilty. I mean, like everybody else, they're innocent until proven guilty. But if they are found guilty, it's a huge deal because, first of all, it could be a significant amount of money, and it will add more fuel to the fire of those people that are opposed to these for-profit Medicare Advantage plans, because one of their arguments is that there is significant incentive, and there is financial incentive, that's not arguable, for them to upcode and to make people look more severe than they potentially are because they get more money in doing so. Aledade might be one of the first ones where it's not an insurance company, but it's a primary care entity. It's an ACO kind of environment that is profiting from helping physicians potentially upcode. That's the allegation.
Yeah, I'm taking a look at this report here from Modern Healthcare. What the suit alleges that Aledade conflated, and they put that in quotes there, anxiety into depression, which in some cases can boost payments by up to $3,300 a year per patient. Yep. They decided that patients over 65 who said they had more than one drink per day had substance use issues, which could bring another almost $3,700 per patient. Now, Ron, this case against Aledade was filed in 2021, and it was recently unsealed because the U.S. Justice Department decided not to pursue it. But this doesn't mean that necessarily that this case is going away, correct?
No, that's absolutely correct. I mean, the Justice Department is really good about, not making any investigation public until they make some sort of determination on it. They believe that people are innocent until proven guilty, which is a good thing. And so the case became public when they unsealed it and said that they were not going to intervene. I think their language was at this time. So I guess they theoretically could go back to it if they wanted to. And that's what unsealed it. The Justice Department didn't state the reasons for declining the case. They never do that. But in other cases, they've made sure to say that their deciding to decline a case has no bearing on the merits of the case, positively or negatively. But no, the case isn't going away because under the false claims law, whistleblowers, which is what this is, can proceed with the case on their own. So it's my understanding that this case is proceeding, that the individual that brought it forward is still proceeding with the case.
Yeah, the whistleblower in this case is Kushwinder Singh, who is described as a senior medical director of risk and wellness product at Aledade. And he says he alleges he was fired after he objected to some of the conduct that was mentioned in this lawsuit. There's been several whistleblower cases in recent years about Medicare plans engaging in fraud, not unsimilar to the allegations here, including one brought against Cigna. How common are whistleblower cases like this for Medicare fraud that's like these allegations?
Well, there's really sort of three types of whistleblower cases on this. There have been whistleblower cases of people that work directly for, provider groups or DME companies or physicians or hospitals, et cetera, and those happen. There have been those whistleblower cases against the Medicare Advantage plans, the insurance companies. This is the first one that I'm aware of that's against an organization like Aledade, whether you call it an ACO or a CIN. I'm not familiar. There may be some of other whistleblowers. So I wouldn't say they're really common. They don't happen a lot. Now, they tend to have, when they do happen, allegations of pretty large dollars attached to them. So they're not frequent, but they're also pretty serious. And some of the awards that have happened on the payer side have been significant.
Mm-hmm. You mentioned that with Aledade, this is the first time it's not an insurance company. Where do we typically see that with the insurance companies, where we see the Medicare fraud? I mean, obviously it's on probably on the Medicare Advantage patients, but where do we usually see that?
Well, it's a similar thing. The Medicare Advantage plans, when they first came about, one of the things that they convinced Congress to do was to give them additional money if they got a more severe patient population. Their argument was they were going to attract the sicker Medicare patients, and they couldn't be held actuarially responsible for that. So there's all these additional payments if they can show that their population is more sick than others. And it's a lot of money. And there have been huge penalties. Cigna just got hit for a bunch of money for quote unquote upcoding. And so there's a lot of money at stake here. And so what the payers have been hit for is falsely reporting higher than necessary diagnosis codes and going after this money. Well, that money starts to flow downhill. What the payers will do is they'll go to an ACO like an Aledade, and they'll say, hey, if you can give us the right coding, make sure that you're, and they'll say accurately coding or fully coding, and that helps the payer get more money. They'll share some of it with those ACOs. And that's in essence what Aledade is accused of, is turning around and telling the doctors, hey, we'll give you a little bit of this taste of this money if you help us upcode, and using software that they developed to do just that, to sort of rig the diagnosis codes. And there's so much money involved that if it's done successfully, the payer can make more money, the Aledade's ACO can make more money, and the doctor can make more money. Mm-hmm. Now, the people who get hurt are you and I, Joe taxpayer.
Yep.
Because, and there's been some studies, and I haven't looked deep into them to know how much I feel like they're valid or not. I just don't know. But there's some studies that are tending to suggest that these MA plans are being overpaid to the tune of about 25% for this kind of activity. So what Aledade's accused of is the same thing that Cigna and others on the payer side have had to pay penalties for. This is the first time that I know of where they're going after a pretty big ACO.
Mm-hmm. Now, I do want to point out before we conclude that in a statement provided to Fulcrum Strategies, Aledade denies any wrongdoing and says the quote, "We do not yet know the full how the full legal situation will play out, but we'll defend ourselves vigorously if needed in a court of law. We therefore will not address any individual allegations." Fulcrum Strategies and the Flatlining Podcast, for our part, we have invited representatives of Aledade to join us on future episodes of the program. You know, as it comes up a lot of times with different court cases, you often hear some people complain that, you know, if we start, you know, going after doctors for their coding practices, it's going to be a slippery slope to, you know, now they're not going to have the independent practice of medicine because they're always going to have the government breathing down their neck about whether or not they're coding properly. Is that a real concern, do you think, for doctors? Should they be worried that all of a sudden they're going to have their coding practices reviewed for Medicare fraud on a regular basis?
Well, you know, to some degree it already happens. Okay. And it happens by the carriers. You know, they'll look for statistical anomalies or things that are, you know, why are you billing a level 5 times more than your colleagues? And those will drive audits. And sometimes there's a good reason for it, and sometimes there's not. Whenever anybody talks to me about sort of doctors and their coding practices, I'm like, well, how is that any different than me filling out my taxes?
Sure. Yeah.
There's right and there's wrong. There's the law. And if I blatantly lie on my taxes, I should be penalized for it. And if doctors are blatantly upcoding, they should be penalized for it. So I don't think it's as much as, you know, somebody pulling out a microscope and saying, well, this is maybe a level 3.5 and you build it a 4. We're talking about some pretty blatant stuff here. And some of the statistics and some of the studies are pretty dramatic, like, you know, over coding something at a rate of like tenfold of what your right. colleagues do. Mm-hmm. Okay. That's probably wrong.
Yep. You know, just as you mentioned that, you know, if you're cheating on your taxes, that's wrong and you should probably be prosecuted for it. I feel the same way about this kind of fraud. You know, you're talking about this or COVID-19, small business loan fraud, you know, because it's like we just said, that's my money that has now been wasted because someone decided to cheat in a particular instance. I know one thing that has come up lately is a Government Accountability Office report that back in 2022 determined Medicare issued $47 billion in improper payments, and it prompted a Republican response in the Senate to get the comptroller for the GAO to do an audit because there's other independent groups that say it's higher. You know, obviously, you know, without us having, you know, any sort of data about what it actually looks like for Medicare fraud, it's happening. What's the solution to going after some of this?
Well, I think there's a number of potential solutions. One is just what they're doing, the auditing. It's the same thing with the IRS and tax, in tax fraud is part of the reason why people, do fill out their taxes correctly is because they're afraid of getting caught. You pay a, $1 million, multi-million-dollar fine as an insurance company, and after a while, those hurt. So I think that's one of them. I personally think we need to really seriously look at the financial incentives and how much money is rolling around in the way Medicare Advantage plans are set up with the insurance companies. We're getting the behavior we're incentivizing. If you put enough money out there, you're going to get people that are going to push for it and are going to do bad things for it. It's the same reason why, the cartels spend so much money getting drugs in this country, because there's a lot of money to be made doing it. And we've created this environment where, and there's been a lot of studies that show that on a per capita basis, Medicare is the most profitable member that an insurance company can have.
Right.
And some of it's because of all this stuff we've loaded into it. We've now then taken that incentive and put it down on doctors who are getting hurt financially with Medicare cuts. So, yeah, I mean, the drawer to the cash register is open, and if you're having a hard time paying rent, you reach for that money. And I think some of these physicians probably don't want to do this stuff, but feel like they have to. And they, and they're upcoding because they feel like it's the only way to survive. I think we've got to take a serious look at the financial incentives, because it's getting us exactly what we should expect in any kind of large financial incentive. And unfortunately, though, there's so much money flowing through these things that it's going to be hard to do, because legislatively it's hard to do. Right. One of the things that, and this is purely, people trying to create enough smoke to where they think there's going to be fire. And I don't have any evidence behind this, but one of the things that people are pointing to the Aledade thing on and saying, wait a minute, this sounds fishy, is just how many sort of governmental connections there are. And they're going, I see, it's the government helping, their cronies. I don't know whether that's there at all or not, but when you've got that much money flowing through these kind of things, it lends itself to those kind of questions.
Well, and I don't know if it's the government funding money to the cronies, but I think it's people who've gotten out of the government who might know where all the loopholes are now.
Exactly.
And whether or not that's the case. Some of the lawmakers that were questioning the Government Accountability Office, they pointed out that it seems like CMS's safeguards to prevent fraud are not working properly. CMS said in a response that they're committed to preventing fraud and protecting people with Medicare from falling victim to fraud. I guess in the grand scheme of things, Ron, how good is CMS at actually preventing fraud?
Well, I would say, to me, the CMS fraud protection stuff, it's a little bit like, trying to measure the effectiveness of, the Border Patrol or the DEA. They catch a lot of stuff.
Sure,
they really do. But given the amount of stuff that tries to get by them and how much money there is to do it, there's a lot of stuff that gets by. I know a guy who's a DEA agent, and he'll talk about, we get a lot of these busts, but boy, there still seems to be a lot of drugs in this country. And the same thing with the Border Patrol, and the same thing with CMS. To truly get rid of all of it, you would probably have to devote an enormous amount of resources to CMS and, multiply their numbers and their budget by a factor of 5 or 10 to truly get rid of it. It's same thing with Border Patrol or DEA. So I think they're dedicated. I think they do the best that they can given the resources they have, but they're never going to get rid of all of it, not when there's this much potential money. One of the studies that I saw that was trying to calculate over the next 10 years these overpayments, which are the money that these people are making if the upcoding is real. It was in the $1.5 trillion over the next 10 years. Mm-hmm. Boy, with that kind of brass ring there, people are going to try it. Sure.
Well, and it's funny too, if they close that issue and cut off that 1.7 trillion, might as well just put that back in the money of doctors' pockets in the Medicare physician fee schedule.
Well, and I will tell you, the people who are opposed to this setup, that's their argument, is we're overpaying, insurance companies are getting really rich, but show me where there's been a true improvement in quality of care or quality of outcome. Now, I will tell you, studying and proving improvements in and quality of care, incredibly difficult.
Yeah.
I'm whenever people talk about quality, I'm always reminded of there's an old Lily Tomlin joke that she said, I'm really worried about all this emphasis of quality control. Are we afraid it's going to get out of control? And I think it's at least a legitimate question. What are we getting for this money? And if we're not getting an improvement in quality or the outcome or the longevities, then yeah, let's take the 1.3 trillion and just give it to the doctors who probably are better at improving quality anyway.
Right. Last thing I want to ask you about, and it's a little bit off the wall, so it may catch you a bit off guard, and I apologize for that. But there was an analysis done in Health Affairs last week or the week before, and the main part was to go after ways to reduce healthcare spending in this country, particularly out-of-pocket spending. And one of the things they mentioned was having a flat Medicare rate for everyone would lower out-of-pocket costs, which I would challenge that a little bit because you'd have to take a look at how much money United Healthcare makes. They can lower out-of-pocket costs if they wanted to. But I wonder if similar to how some have argued that if you had a flat tax with no deductions, no credits, and just 10% for everyone, that would get rid of a lot of the tax fraud that we have because there's no loopholes to go through. Would something like that for Medicare work in the same way that, just pay everyone the same? Maybe change it based off of geographic location, but get rid of all of these incentives, get rid of all of these ways to make a little extra money regardless of the quality of care kind of thing. Do you think that would help prevent the fraud and save some of this money that's being wasted, or do you think that's a little bit more wishful thinking?
Well, there's two things that are involved in that, and the talk about the flat tax is a very good analogy. If you make a flat tax, you could get rid of an awful lot of the IRS from the auditor's perspective. It would be easier. CPAs wouldn't like it because it's really easy to fill out your taxes. Mm-hmm. And so there's a lot of positives to that kind of. Now there's a lot of negatives too. Because there's a huge segment of our population that in essence doesn't pay federal tax, right? Because their income is below it, or their child deductions or whatever is such that they don't have to. And those people are going to have to pay. So it's not great for them. And there's a lot of people who pay a rate that's significantly higher than that even if you get rid of their deductions, that are pretty well off financially, that are going to win even more. So it's not as easy as saying this isn't without side effects. It's like a drug. Yeah, it'll help, but it's also going to create the following side effects. When you talk about the sort of the single payment thing for Medicare, sure, it could get rid of some of that fraud. But there are definitely primary care groups who the only way that they're surviving now with Medicare population is those additional, payments. Same thing happens with Medicaid at primary care. If you went to straight across the board, people only get paid Medicare, you are going to drive some primary care groups either out of business, or you're going to put them in a situation where they're going to say, well, then we can't care for Medicaid anymore or Medicare anymore. And so one of the harmful side effects, since we know that straight Medicare reimbursement does not cover the cost of care, is you could find a significant reduction in access to care for seniors and poor people. And one could argue they're probably the populations who need it the most.
Right.
Mm-hmm. So it's one of those things where there's no silver bullet, there's no easy answer, and there's no prescription to this problem that isn't going to have some negative side effects. As one last thing, as an oncologist that I talked to one time in a meeting said, hell, rat poison at a enough dosage will cure cancer. Now, it kills the patient too, but it takes the goods with the bads.
Yeah. Yep. Well, Ron, on that note, we're just about out of time. So thanks again for sitting down with me today. And everyone else, you can find more information about this Aledade report and information on the Medicare fee schedule at flatlining.net or in the show notes for this program. Next week, we've got another special edition coming up. We're talking to a radiologist about AI and radiology, whether or not it's going to help patients, hurt patients, what the outlook looks like for that new technology in our healthcare system. Thanks for joining us on the Flatlining Podcast. Miss an episode of the Flatlining Podcast? Well, now you can read a recap. Just go to flatlining.net and look right there on the homepage every Monday for a written recap on last week's episode.